Normal RBCs are biconcave discs. They are designed to be flexible and be able to pass through narrow splenic cords and capillaries. But in hereditary spherocytosis, because of a membrane defect, these RBCs become small, dense spheres, because of which they find it difficult to pass through these small splenic cords and are eaten up by macrophages in the spleen. Let's see how this happens and what are the consequences. I am Nabeel and this is Pathocyte. In hereditary spherocytosis, the main problem is a membrane protein defect. This is most commonly inherited as an autosomal dominant pattern. This causes loss of membrane, because of which the surface area decreases and the RBCs end up in a structure with the least surface area but maximum volume, which is a sphere. Now let's look at the main proteins which are affected. Okay, this is an RBC membrane, and like all biological membranes, this is a lipid bilayer. The shape of this membrane is maintained with the help of a scaffolding, which consists of a few proteins. Let's look at the most important ones. One is spectrin, along with actin. Spectrin and actin are attached to the lipid bilayer with the help of ankyrin and band 3. So these are the most important proteins. So spectrin and actin are spread all across the membrane and it is anchored onto the membrane with the help of ankyrin and band 3. Defect in any of these proteins can lead to membrane defect and hereditary spherocytosis. Now let's see what happens in the spleen. Normal biconcave disc-shaped RBCs are deformable, and so they go through the splenic cords without much trouble, as they are quite flexible. But in hereditary spherocytosis, these dense RBCs are not flexible and they sort of get stuck while going through the splenic cords, and they are eaten up by splenic macrophages. This causes extravascular hemolysis. So till now we learned that hereditary spherocytosis is an inherited defect of RBC membrane protein. This membrane defect leads to the change in shape of RBCs from a biconcave flexible disc into a rigid sphere, and these spherical RBCs find it difficult to go through splenic cords and are eaten up by splenic macrophages. This is the basis of hereditary spherocytosis. Now let's look at the clinical features. If you think about the mechanism, clinical features become quite simple. As most of the RBCs are destroyed in the spleen due to extravascular hemolysis, you get anemia. And the heme in the destroyed RBCs finally gets converted to bilirubin. And since bilirubin increases, you get jaundice. And when the liver excretes lot of bile, pigment gallstones are formed inside the gallbladder. Now let's look at some important investigations for hereditary spherocytosis. When you do a complete blood count, you get to see that the size of the RBCs are sort of normal to slightly reduced. Means mean corpuscular volume can be normal or slightly reduced. But the striking difference from all other conditions is mean corpuscular hemoglobin concentration. What happens to this? As most of the RBC membrane is lost, when the hemoglobin within the cell is remaining the same, the concentration of hemoglobin within the cell is relatively increased. So, mean corpuscular hemoglobin concentration increases. Now, when you see the peripheral blood smear, you see spherocytes. These are smaller RBCs which seem denser because of lack of central pallor. This central pallor is lost in these spherocytes. Along with this, you get to see slightly larger RBCs with a mild bluish hue. They are reticulocytes. They are nothing but young RBCs which are released by the bone marrow because of increased erythropoietin due to anemia. Coombs test is negative in hereditary spherocytosis because there are no antibodies involved. This helps us differentiate hereditary spherocytosis from autoimmune hemolytic anemia. That is another condition where you get spherocytes. Osmotic fragility test checks for the fragility of RBCs in a hypotonic solution. Spherocytes are easily fragile, and in a hypotonic solution they burst easily. Nowadays, EMA binding test using flow cytometry is used as a very fast screening test. Now let's jump into some clinical implications. As we already saw, spleen is the place where all these RBCs are eaten up. So if you can do splenectomy, anemia in hereditary spherocytosis improves. But the spherocytes persist in the circulation as the basic defect is not resolved. Aplastic crisis is something we need to touch upon before ending this discussion. Parvovirus B19 infection can inhibit erythropoiesis within the bone marrow. So in this situation, no new RBCs are formed for about 2 weeks, which is the approximate time which the body takes to recover from a parvovirus B19 infection. Now, the problem with hereditary spherocytosis is that already the lifespan of RBCs is reduced from 120 days to 10 to 20 days in all patients of hereditary spherocytosis. Now, when production of RBCs is stopped, whatever RBCs are there in the circulation will die off within this period. So there comes a crisis period where there are no new RBCs and all the old RBCs are destroyed. This leads to a sudden severe anemia. This is aplastic crisis which occurs in hereditary spherocytosis. To summarize, hereditary spherocytosis is an inherited condition where membrane defect leads to the formation of spherocytes which are rigid and they find it difficult to go through splenic cords and are eaten up by splenic macrophages, leading to extravascular hemolysis, which leads to anemia, splenomegaly, jaundice and gallstones. This condition can be diagnosed with the help of CBC, where you see anemia and increased mean corpuscular hemoglobin. Coombs test is negative and peripheral smear shows spherocytes and reticulocytosis. We also touched upon aplastic crisis which occurs due to parvovirus B19 infection. If you have any doubts, please ask in the comments. In the next video, we'll look at another hemolytic anemia which is pretty common in the Mediterranean and surrounding regions, which is G6PD deficiency. Think at the cell level.